Thank you. In the beginning, I want to thank Dr. Ines and Dr. Yasser who invite me in this conference. Today we speak about obesity and CKD. In the beginning, we have known that obesity was defined as an increase in body weight that was greater than 20% of individuals' ideal body weight, and the body mass index is the accepted standard measures of overweight and obesity. But body mass index has some limitation as it affected by the extracellular volume expansion, but offer a good reflection of total body fat. Obesity is subdivided into three categories and three classes. Class 1 is body mass index from 30 to 35 kilogram per meter square, and class 2 when body mass index 35 to 40 kilogram per meter square, and class 3 is more than 40 and more than 40 kilogram meter square. However, waist-hip ratio and skin fold thickness are superior to body mass index for the correct classification of obesity in CKD. Obesity is one of the epidemics. Its prevalence is higher than 30% in the USA, and it is estimated to increase by 50% in 2030. And obesity is estimated to account for approximately 20% to 25% of kidney disease worldwide. So there is association between obesity and kidney through direct pathway and indirect pathway. We know also that obesity and metabolic syndrome can cause diabetes mellitus, hypertension, hemodynamic factors, lipotoxicity, insulin resistance, and inflammation. And so there is a relation between obesity and chronic kidney disease through the comorbidity, through the hyperglycemia, abnormal renal lipid metabolism, and the hypertension. Obesity patients with kidney disease show glomerulomegaly and mesangial expansion with increased blood flow, hyperfiltration, and albuminuria with other damaging mechanisms, all this leading to progressive decline in the GFR. So there are three main mechanisms that the obesity affects the kidney: through the hemodynamic pathway, through the adipose tissue-related pathway, and the insulin resistance. We will take the first pathway with the hemodynamic pathway, in which the obesity increases the sympathetic activation and increase the gastrorenal axis modulation, causing gut microbiota change and renal compression. All of this will cause increased renal tubular sodium reabsorption and activate the RAS system. All of this will lead to volume overload, hypertension, glomerular filtration, and albuminuria. The another mechanism with the increase the adipose tissue, leading to increase the leptin secretion and decrease the adiponectin decrease and increase some inflammatory markers and aldosterone and angiotensinogen secretion, causing a stimulation of the RAS activation and inflammation and oxidative stress that affect the kidney. Also the insulin resistance, causing increased insulin secretion. All of these mechanisms causing kidney injury and fibrosis. When we take the first one, the hemodynamic pathway, in which the obesity increases stimulation of the tubular sodium chloride reabsorption from the proximal tubules and the lobe of Renal, that leading to, through the renal medullary compression, leading to decrease the sodium delivery to the macula densa, which stimulates the macula densa to increase more stimulation for the RAS activation. All of this would lead to renal vasodilatation and volume expansion, causing arterial hypertension and glomerular hypertension. At the end will end with glomerulomegaly and glomerulosclerosis. In non-obese patient, in this diagram, we show that the normal afferent and efferent arterioles and the normal podocytes. During the obesity, there is a dilatation of the afferent arterioles and lead to impaired autoregulation of the kidney, increasing the capillary diameters and increase the capillary wall tension and decrease the podocyte density. All of this is caused as a parotrauma that leading to other causing proteinuria and albuminuria. The adipose tissue, when increase the adipose tissue, there is a decrease the adiponectin, increase leptin, resistin, and vasvatin, and this increase the insulin resistance, increase the insulin level, increase the RAS activation, inflammation, and oxidative stress. These factors causing comorbidities as diabetes, hypertension, and the cardiovascular disease, and also all of both will cause chronic kidney disease. What is the effect of adiponectin? Adiponectin, one of the markers that decrease, on the inflammatory markers that decrease during increase of the adipose tissue. With the adiponectin decrease, there is a reduce the adiponectin receptor on the podocytes and reduce the adenosine monophosphate kinase activation and increase the inflammation. All of this leading to the podocyte food process effacement, followed by the early onset of albuminuria and the hypertension. So, leptin can affect the glomeruli by mesangial cell hypertrophy and basement membrane thickening, leading to albuminuria and glomerulosclerosis, and decrease the adiponectin causing fusion of the podocytes, leading to decrease the glomerular filtration rate and also albuminuria. The another pathway is the interaction between the adipose tissue and the microbiota in the kidney. When the adipose tissue increase, there is increased adipose-derived factors. These adipose-derived factors with the uremic toxins in CKD patient, but causing increased disruption of the intestinal hemostasis, leading to leakage of the inflammatory factors through the gut and increase the inflammatory response, which increase more inflammation of the kidney and causing more damage of the kidney that release more inflammatory cytokines. The another mechanism in the interaction between the gut and the kidney. In normal patient, when the patient ingests sodium, which is sensitized by the sodium channels that present in the G cells in the stomach, leading to release of gastrin and L-DOPA. This gastrin and L-DOPA will inhibit the sodium reabsorption from the proximal tubules and the loop of Renal and cause sodium diuresis or increase the diuresis and lead to decrease the secretion of sodium. In obese patients, this mechanism will be affected. So it leads to more volume expansion, lead to more absorption of the sodium, leading to cause afferent dilatation and increase the intraglomerular pressure, and this end with glomerulosclerosis. This study, they found the spectrum of kidney biopsy finding in patients with morbid obese. They take a 3,263 native kidney in obese patient with body mass index more than 40 kg per meter square. They find that 12% of these patients have obesity-related glomerulopathy, and 18% have obesity-related glomerulopathy and the other lesion mainly due to hypertension or acute tubular necrosis, and 67% having another lesion. This study showing that the effect of obesity-related glomerulopathy highlights the importance of renal biopsy in obese patients. And they found that in picture A, they found that there is a prominent focal segmental glomerulosclerosis, and in picture B, there is a focal segmental glomerulosclerosis and severe interstitial fibrosis. Also, in this patient with obese patient, we'll take a biopsy showing a prehilar focal segmental glomerulosclerosis with glomerulomegaly. This meta-analysis study, it was done in 2200. It found that this study was about 247 articles by PubMed and 25 cohort study and 3 cross-sectional study and 19 case control study. This meta-analysis found that obesity in women was associated with high risk than men, and obesity increased the risk of chronic kidney disease in general population in women more than men, and also obesity can cause a progression of kidney disease among patients with kidney-related disease. Obesity in advanced CKD and dialysis patients, it is a paradox. There is a paradoxical finding that found that even morbid obese patients predict better outcome in dialysis. However, anthropometry and dual energy X-ray absorptiometry is modeled to be the assessment for obesity in advanced CKD and dialysis patients than body mass index. And the findings that different studies suggest a survival advantage from gaining fat mass is lower than from gaining lean body mass. And the large body size by fluid retention, not fat, by fluid retention has a poor outcome, while fat mass and muscle mass is more favored. And they found this study that it was a reverse epidemiology, as patients with advanced CKD or dialysis patients who become more obese, not underweight, have a better survival than another who are underweight. In advanced CKD, a high body mass index is associated with better survival. Losing weight in the stage of dialysis must be avoided, and maintenance of body weight are proven to increase muscle mass and functional outcome by adequate nutrition. Physical activity is mandatory to avoid weight loss or development of sarcopenia. And this study was done showing the influence of excess weight on mortality and hospital stay in 1,346 hemodialysis patients. They found that the patient who underweight in dialysis was a high risk for mortality than patient with overweight. And this reverse epidemiology study was done between hemodialysis patient versus general population. They found that patients on hemodialysis who are high body mass index or more body weight had more survival than the other general population. So obesity in advanced CKD have many advantages: more stable cardiovascular profile, more resistant against infection, high circulating lipoprotein into toxins. So large muscle mass and high strength muscle, large adipose tissue, more subcutaneous fat, because a less cardiovascular infectious event. What is the role of obesity in kidney transplantation? The impact of obesity body mass index more than 35 kg per meter square in kidney transplantation associated with a delayed graft function, increased risk of patient death, increased risk of acute rejection, increased risk of allograft loss. But obesity is not considered as to be a contraindication for kidney transplantation according to the most clinical practice guidelines. But body mass index, when increased, decrease the incidence or decrease the chance to be transplanted or to do a cadaveric transplantation outside. They found that among women who have a high body mass index, the incidence of receiving kidney transplantation was decreased. The French Cohort study, this was done among 4,691, including patients. There was 747 patients were considered obese with body mass index more 30 kg per meter square. They found the renal transplantation outcome in obese patients. They have a high incidence of mortality, high incidence of serious bacterial infection and cardiac complication. Also, the Austrian and New Zealand dialysis transplantation registry found that there is no independent or associated obesity between patient and graft survival, but there is an increased incidence of delayed graft function and acute rejection. This meta-analysis study about the consequence of recipient obesity on post-operative outcome, it was done on 2,400 patients, showing a result for delayed graft function and increased risk of patient death, but increased risk of presence of biopsy-proven acute rejection and allograft loss. So, in obese patients who undergo transplantation, there is a difficulty to achieve an adequate exposure to immunosuppression, or so frequent overexpression or underexposure. Also, there is a surgical intervention will be complex and may increase the risk of surgical complication. Increase the risk of surgical wound infection with a range from 200 to 30% in patients with body mass index, means 30 to 40 kg per meter square, and up to 40% in patients with body mass index 40 kg per meter square. But what is the management of an obese patient in adult with CKD? The first thing is lifestyle management of obesity. Balanced diet, no smoking, no alcohol, no drugs, physical activity, and regular and adequate sleep. They found in 2,200 studies that the lifestyle modification by low-caloric diet, physical activity more than 150 minutes per week of aerobic physical activity, and behavior therapy will decrease the proteinuria, will decrease the albuminuria, and will increase the glomerular filtration rate by the hypocaloric study. And what is the medical treatment? Is only alone medical treatment can be save the patients? No. Medical treatment is only a piece in a puzzle that includes physical activity, nutrition, and behavior therapy. And anti-obesity pharmacological therapy should always be established together with nutritional behavior assessment and physical activity advice. The first one is the orlistat. Is a gastrointestinal lipase inhibitor that avoids fatty acid intestinal absorption, and weight loss is about 55%. Related to malabsorption, especially of fat-soluble vitamins, so associated with renal stones, mainly oxalate stones. But orlistat is associated with increased risk of acute kidney injury due to oxalate nephropathy and may cause a progression of chronic kidney disease. Liraglutide, it is a glucagon-like peptide 1 receptor agonist, reduces appetite, delay gastric empty, and balancing insulin and glycogen secretion time. High dose of 3 mg per day benefit in obese patients with 5 to 10% reduction of body weight. But they have a side effect, nausea, vomiting, constipation, and diarrhea, and not be used in patients with personal or family history of medullary thyroid cancer or multiple endocrine neoplasm. Bupropion is used for smoking cessation and depression. It inhibits appetite and increases energy consumption. Naltrexone is an opioid antagonist that also inhibits food intake, and their combination has a synergistic effect. But side effect, nausea, emotional and psychological disorders, and increase the seizures, the risk of seizures, and increase the incidence of suicide, maybe stop these drugs. Combination of phentermine and topramide drive a weight reduction through increased satiety and energy waste, reduce caloric intake, and taste abnormality. These 4 drugs will have a FDA approval. Anti-obesity medication, only the orlistat and liraglutide can be used in the treatment of obesity in CKD patients. However, orlistat have reports of acute kidney injury and chronic kidney injury possible from oxalate nephropathy. Renoprotective medication, not specifically approved by FDA to treat obesity, can treat chronic kidney disease but not obesity. Sodium glucose cotransport 2 inhibitor may have a weight-lowering effect in persons with CKD. Metabolic surgery offers the most effective treatment for obesity, the most common being sleeve gastrectomy and raw gastric bypass, but they have a drawback metabolic effect on surgery in CKD patient with high cost effect, reoperation, readmission, acute kidney injury in CKD patient compared to general population. This last slide when showing the mechanism of obesity with class 1, we have to lifestyle therapy and or anti-obesity medication if inadequate weight loss or control risk factors, or if weight is preventing kidney transplantation. If no, continue on lifestyle and anti-obesity medication. If yes, combination of lifestyle, anti-obesity, and consider bariatric surgery. In class 2, as class 1, life-based and anti-obesity, and if inadequate or if transplantation is weight prevented, if these obesity prevent transplantation. If no, combine on lifestyle-based therapy and anti-obesity medication, and consider. If yes, we should do a bariatric surgery. Class 3, from the first, combination of lifestyle-based therapy, anti-obesity, and bariatric surgery. Thank you.
Thank you, Professor Amr, for your elegant talk. الحقيقة استمتعنا بيها. بس في بعض الحاجات زي مثلا في super added causes for combination of renal disease in obese patient, like the presence of fatty kidney now.
حاولت بس الخص حاولت الخص الكلام على قد التايم يعني.
And another hyperuricemia. Also it is a factor. And also in patients who reduce the body weight acutely, the mobile kidney, which will be pelvic kidney and will cause UTP infection and so on. As regard the drug therapy in the treatment of obesity, there is quite a loss of large amount from them not used in Egypt, like naltrexone, amphetamine, phentermine, all of this. We also use the liraglutide, the orlistat, like you said, and the third one, sometimes we use SGLT2 with metformin. Thank you.
شكرا دكتور عمرو على المحاضرة الجميلة دي. تعليق على كلام حضرتك دكتور رأفت، الفاتي كيدني كونسبت مش موجود عندنا قوي زي الفاتي ليفر. يعني ذات انجوريوس ابتدى. بس regarding الهايبريوريسيميا and its role in CKD برضه still debatable، يعني في yes or no not that just proved زي الكارديولوجي كذا فاكتور فور progression او ريسك فاكتور. يعني في لسه still مش قادرين نقول بالظبط ان احنا we are to treat even asymptomatic hyperuricemia in every cases to delay progression. دكتور عمرو، انا جالي امبريشن ان الاوبيزيتي مفيده في الدياليسيس بيشنت. يعني انا كنت متوقع ان هنشوف العكس، الاوبيزيتي ده حاجه هازارds. انا استغربت ازاي تقلل الكارديوفاسكولار مورتاليتي، ورغم ان الاوبيزيتي بيرسي معروفه انها يعني في طبعا كارديوفاسكولار ريسك.
هي كل الابحاث حضرتك او كل ستاديز قالت ان في ريفيرسد ابيديميولوجي. دي حاجه ما حضرتك عارف طبعا في ريفيرسد ابيديميولوجي الناس اللي على دياليسيس، ولكن هو اشترط ان جين ويت نوت فلويد ريتنشن زي ما حضرتك، مش فوليوم اوفرلود. لا احنا بنتكلم
يعني
على
جين ويت فات ريتنشن،
فات اند
ماسلز يمكن
يس فات اند ماسلز
بالذات، يمكن ماسلز هيكون اكتر، ده يكون اكسبلانيشن ان هو يقلل الكارديوفاسكولار مورتاليتي على الدياليسيس اكتر من فات.
اما قال لك ان الناس الاندر ويت لا الانسيدنس اوف هاي مورتاليتي اند انسيدنس اوف كارديوفاسكولار افكت يبقى اعلى.
احنا بنتكلم في اندر ويت اللي هو المال نارش دياليسيس بيشنت، دي قصه ثانيه بقى.
ولا والويت بتاعه كويس برضه. يعني حكى الجراف قال لك ان كل ما الويت يزيد كماسلز وفات يبقى احسن من اللي هو النورمال ويت بتاعه. ده الريفيرسد ابيديميولوجي ستادي.
مور لوجيك يا دكتور، مور لوجيك انه لو قارنا الاندر ويت بالنورمال ويت ديفينتلي هتبقى مفيد.
يعني
قارن الاوبيزيتي بالنورمال ويت اعتقد مش هتبقى في مصلحه الاوبيزيتي الا اذا كان عند حضرتك تفسير.
ما هو الحاجه هي دي
مع الاندر ويت، لو قارنا الاندر ويت
هو لو الويت جين، لو احنا بنتكلم على ماسل بيلت ماسل ماس، ده انديكيتس ان بيتر دياليسيس بيتر كونديشنز اول اوفر سراوند كونديشنز. ما هو مش هيبقى بيورلي ماسلز طبعا، يعني لازم يبقى في اماونت، لكن يمكن هي دي النقطه. لكن ان كومباريزون مع الاندر ويت، لكن لو مع النورمال ويت
لا يعني حاجه الريفرسبل ايميون ستادي دي معموله كذا ستادي، مش ستادي واحده قالت الكلام ده،
متهيألي
واخد بال حضرتك؟
ممكن نعمل عليها محاضره لوحدها بقى تفسير للقصه دي.
lastly زي ما بنتكلم هنا على ال value of weight in cardiac patients. الحقيقة في value في obesity. obesity مفيدة في بعض الحالات. زي ايه؟ زي لو لاحظنا ان البيشنت بتعمل سبورت لللمبر فيرتبري، لو العيان عمل رابيد ويت لوس بتلاقي العملية باظت معاه خالص وبدأ يحصل له اوستيو ارثرايتس. تاني حاجة الموبايل كدني، لو سيبنا شوية الفات موجودين هم بيحافظوا على الكلية فوق، بس ده مش اكسكيوز الحقيقة ان احنا نقولها، ولكن هي من ضمن الحاجات اللي ممكن نستعملها. شكرا استاذ عمرو.